Moshe, how about pacritinib, momelotinib, all those other ones?
Those are still pacritinib and momelotinib are still experimental drugs. Each one of them, as a general statement, each one of them in fairly extensive studies are somewhat less efficient as far as splenic response and as perhaps symptom control compared to ruxolitinib. So the claim to fame is not on increased activity, and when we say claim to fame is an effort to get this drug approved. The claim to fame of pacritinib is activity in patients with low platelets, and that drug has substantial positive effect on patients with less than 50,000 platelets, and I think that that's the approach the company is taking to further explore this option. And I think if they have a chance to develop the drug, that's the area. I cannot quote you numbers, how much do patients improve and to what extent, but we have seen some platelets responses. Momelotinib has a substantial...
Actually, I'm going to turn to Mary Frances.
Okay, sorry.
It's okay.
Go ahead.
So momelotinib trials have been done. Unfortunately, I think they picked the wrong endpoint for the trial because this was a drug that showed promise in patients who were anemic, which is obviously a huge unmet need. My experience is always small, but certainly the patients I had in the trial, it was really quite exciting, the fact that they seemed to get good responses to their anemia. But that was not the primary endpoint of the trial. But I understand that they're now going back and that there's another trial about to enroll. So I think momelotinib probably has something to offer in the future because a drug that improved the anemia would be very helpful.
And John, anything else coming down the pike? Anything you're interested in?
Yeah, I mean, I just want to add that. I think that I can envision a world where you have multiple JAK inhibitors at your disposal, whether it's, as Moshe said, patients with low platelets where pacritinib could fill that unmet niche in a patient population that does terribly and has a dismal prognosis with no real therapeutic options, to patients with significant anemia where Mary Frances put that momelotinib may be an option where you're guaranteed to get anemia with ruxolitinib. I think beyond that, we're really looking at second-line therapies in a patient group that has a median survival that's about 12 to 14 months, and there's no approved therapies and very few very effective therapies. So I think that's where a lot of the clinical trial focus is right now, adding drugs to ruxolitinib to synergize, hopefully with preclinical rationale to inform those early phase studies.
Can you comment on the BET inhibitor and the LSD1 inhibitors?
So CPI-0610 is a pan-BET inhibitor. It's an oral drug. It's given 2 weeks on, 1 week off. It has really been not impressive in other myeloid malignancies, but in myelofibrosis, it does have activity. And if you go back to papers that Ross Levine and Maria Kleppi have published, it seems to converge on the NF-kappa B pathway, which is upregulated and promotes pro-inflammatory cytokine signaling. So the combination of those two drugs in the MANIFEST study, which is a phase 2 study, which we'll present the results at this meeting, was impressive. For a patient population that was destined to not do well, we saw spleen responses, symptom responses, and even anemia responses and regression in bone marrow fibrosis. And this is still in a growing patient population. The study is ongoing, but at least gives us some confidence that that may be an active agent and a pretty well-tolerated agent, too.
LSD1, which is another epigenetic regulator. BET inhibitor is an epigenetic regulator by interfering with the activity of bromodomains, whereas LSD1 interferes with chromatin methylation. This one, the LSD1, also has activity as far as symptom control and some minor activity on spleen size, some splenic regression. So because they both may work on the NF-kappa B pathway, which is kind of complementary to the JAK-STAT pathway, it seems that these drugs or these agents offer some promise as far as additional control of the inflammatory process in this disease.
Yeah. There's a few other just quick drugs, luspatercept, either in combination or alone in patients with anemia, myelofibrosis being investigated. There's the AVID 200 with the MPDRC, and the PRM 151.
You think it will come back?
Maybe.
It was sold to another company. It's in the hands of Hoffmann La Roche. We hope it will come back, but meanwhile it's active in pulmonary fibrosis.
Yeah,